Good evening. First of all, many thanks to the network for this initiative. It is very much appreciated. It falls within the initiatives that we do on a national basis from the National Antibiotic Committee. If you want to access the website, it's nac.gov.mt. And the idea today was that I would give a brief outline on antimicrobial resistance, why is it important, what is the situation in Malta, and then our guest speaker will follow on initiatives that the public can take. So, are you hearing me from the back? Because unfortunately the loudspeaker has had a bit of a hit this week, so not exactly ideal. So if you hear me coughing, I'm not infectious and I didn't take any antibiotics, I can assure you. All right, so where do we start? I think it's worthwhile starting, since we're talking about it, actually on the infections themselves, because that is where ultimately the process starts. So it's very important, and I apologize if some of what I say is already old hat for you, but I thought I would start from basic and then work my way up. So infections, unlike what we very often hear even from our own medical colleagues, they are not all caused by viruses, right? Because in Malta we have this colloquial saying, you have an infection, it's a virus. Okay? Well, no, there are many different types of microbes that cause infections, ranging from very rare causes, which are called prions, which you may remember some 30 years ago, there was this furore of mad cow disease. That is what causes that infection. Then there are fungi, okay? You've heard about malaria, that's a parasitic infection. These are rare, and we're not going to even touch on them. But the key, the two most important types of infections that we encounter are those caused by viruses, yes, but also by bacteria. And in general, viruses tend to cause what I got last week, these common infections, especially of the respiratory system that we get especially in the winter time. Bacteria tend to cause more serious infections, especially infections that happen up the road here at Mater Dei, where all the serious infections are primarily bacteria. And why is this important? Because each of these types of microbes have their own medicines or pharmaceuticals to address them, to try and cure the infection. And what we will be focusing on today are the antibiotics. And the antibiotics work against the bacteria. Right? They do not have any effect on viral infections. And I will have a number of slides today, but if you leave here with just this message, I think it's already sufficient, and that's something that we need to really, and we will continue to emphasize throughout this half an hour that I have with you. So what is resistance? So basically, we start here, okay? So we have these antibiotics. These antibiotics work against bacteria that cause these serious infections, infections of the blood, infections of the urine, infections of the lungs, okay, pneumonias, infections after surgery, these infections that happen in the operating wound, okay, all of these are caused by bacteria. And antibiotics therefore work against these bacteria. What happens in antimicrobial resistance is that, let's talk about mainly bacteria, these bacteria change their structure. So whereas before they were able to be destroyed by the antibiotic. So for example, the bacterium, we go back, okay, you can see there, do we have a, yes, here. Okay, so you can see the bacterium, it has a cell wall. And some of the most common antibiotics, penicillin being one of them, actually destroys the cell wall. And that is how it therefore kills the bacteria. But bacteria find a way of stopping the antibiotic from destroying their cell wall. So they remain viable, they remain alive. So whereas before that antibiotic used to kill that bacterium, now that antibiotic no longer is effective against that same bacterium. And this is critical, because therefore, if the antibiotic is no longer effective, then that antibiotic will no longer work on the infection that that organism, that microbe causes. And if that is a serious infection, if that is a bloodstream infection, okay, which is obviously one of the worst infections you can get because the blood is all over the body, then of course that has significant repercussions in terms of patient outcomes. So why are antibiotics important? Well, because modern medicine depends on antibiotics, right? So yes, they are important because if you are usually a woman and you get a urinary tract infection, it's inconvenient, it's, urine hurts, but probably it will go away after some days of rather uncomfortable urination. But if you are in hospital, if you need, for example, surgery. So if you need surgery and we don't have antibiotics, your risk of an infection after surgery can be up to 50%, especially if you operate on the sites of the body where we have lots of organisms, such as the large bowel. Okay? So in our intestine, we have billions and trillions of bacteria. So if you have a cancer of the bowel and you need to remove part of the intestine to treat that cancer, you can guarantee that if you don't give the patient antibiotics during the surgery, then that patient will get a very severe infection and will probably die from the infection. So antibiotics are critical for this. Again, we hear about people having accidents and then ending up in intensive care, in ITU. Again, ITU medicine is completely ineffective if you do not have antibiotics, because the treatments that we use are so aggressive that patients will ultimately get infection unless we prevent it. And finally, the third example, and there are many others, cancer. So when we have cancer, we use treatments such as chemotherapy to destroy the cancer, but at the same time it also destroys our immune system. So we are open to infections, and again, without antibiotics, cancer treatment will never be able to happen. Or else it will happen, but the patient will die, not from the cancer, but from the infection. So if we lose the antibiotics that we have, and we have very few antibiotics coming up, new antibiotics, we haven't had a new antibiotic for a decade, all right? So what we have, we need to keep and we need to maintain. If we lose what we have, then we have a problem, because 10, 20, 30 years in the future, these essential treatments will be in jeopardy. And there are also other issues, okay? It's not just, and it's very important, obviously, the patient harm that happens without antibiotics or because of antibiotic resistance, but financial costs, for example, okay? So let's talk more about this patient harm. Okay? At the moment, the estimate is that globally about 700,000 people die from infections caused by organisms which are resistant. In other words, on which antibiotics cannot work. If we continue this trend, by 2050, that will be 10 million. It will be much more than cancer, than road traffic accidents, etc. on a global scale. This is the level we're talking about. So how does this happen? How do the bacteria become resistant? Now, most of the bacteria that we have are accustomed to an environment where they need to compete with other bacteria. So, for example, if you go to Chadwick Lakes, it's full of water at the moment, all right, and you take a sample, you will grow hundreds of different bacteria. And these are competing against each other to survive in the environment. So what do? They produce antibiotics themselves to try and kill off their competition. So what does the competition do? It tries to find ways and means in order to withstand, the antibiotics that the other bacteria are doing. It's It's a really mundane example, but every day we talk about the Ukraine war. Russians throw the missiles and the Ukrainians try to knock them down with their defenses. And the same thing with bacteria. So in our body, as I've already alluded to, we have trillions of bacteria. We have something like 3 kilos of bacteria. So if we were to remove all our bacteria, we would be lighter by 3 kilos, immediate diet. But we would be dead within a day or two, because those bacteria are essential for our body to function normally. So those bacteria, we find them mainly in the bowel, in the large intestine. We find them on the skin, okay? We find them also in the mouth and the upper respiratory tract. Those are the main areas where it happens. So what happens is when these bacteria that are present in our body taste antibiotics, okay, or are subjected to antibiotics, the antibiotic will kill many of those bacteria. However, bacteria multiply extremely rapidly. So every 20 minutes, a bacterium divides into 2. And whenever they multiply, sometimes a defect happens in their genes. And those genes change. Now, if that change is useless for the bacterium, then nothing will happen. But if that change means that the bacterium is now able to withstand the antibiotic, so what happens is that the antibiotic will kill off all the other non-mutated bacteria and leaving just the bacteria which are now different, which are now resistant. And those bacteria will multiply and they will spread, especially by contact. So these are the 2 key elements: the antibiotic exposure and the spread. We'll talk mainly today on the antibiotic exposure, and we'll talk about overprescribing. We'll talk about patients not taking the antibiotics correctly or asking for the antibiotics when they're not needed. And we'll also touch upon their use in agriculture. But for example, in the hospital setting, we also emphasize, and our speaker mentioned that this is my main area of concern, about infection control. Making sure that those bacteria do not go from one patient to another by getting our healthcare workers to wash their hands, to use alcohol rub, to disinfect properly, to use correct procedures, etc. And this is a very complex situation, okay? So in this case we have George here. Okay, George has been given an antibiotic by his doctor. He didn't really need it, but he now developed this resistant bug in the bowel in the way I told you. So George may be an 80-year-old, he may be in a nursing home, he may need hospitalization. So that germ is going to spread, as I said already, to others. Even if George doesn't go to a hospital or a nursing home, it can also be spread in the home. But there's another exposure that is important, and that we saw in the video, in animals. Okay? So animals are also given antibiotics, sometimes when they're needed, often when they're not. And they also have the risk of developing these resistant bugs. So then, either if we eat the meat from these animals, especially if we don't cook it properly, or even if we cook it properly, if, for example, we have a chicken that has been exposed to antibiotics, it has a salmonella in its bowel, the salmonella has become resistant, you have chopped up this chicken on a chopping board at home, okay, and you haven't cleaned the chopping board properly. So then you put a sandwich on it, and those bacteria will then go on the food that you are preparing on the same chopping board. And you get the infection with a resistant organism. So as you can see, it's a very complex, situation. And the European Union and the WHO have termed a One Health approach. So it's not just human medicine, it's not just animal medicine, but because there is this interlinking, it's a One Health initiative that we do. And there is also another important element when we're talking about antibiotics. It's not getting the antibiotic alone. but it's also which antibiotic you are getting. So there are some antibiotics which we call narrow spectrum. So this is an example here. Antibiotic 1, as you can see, is only effective on bacteria B, a small proportion of bacteria. On the other hand, antibiotic 8 is effective against B, C, D, E, F, and G. So this is a narrow spectrum. This is what we call a broad spectrum. It kills a lot of different bacteria. Why is this important? Because narrow spectrum antibiotics tend to cause less resistance than broad spectrum. Because obviously, if you have a broad spectrum antibiotic which you've taken orally, it goes into your bowel, then the chances are that it will hit at least 1 or 2 of the bacteria in your bowel. Where if it's a narrow spectrum, then in that case, it is unlikely to cause resistance. Antibiotics are unique, okay? And it's not just because they're my focus of interest, but they are unique. So with any other pharmaceutical, whether this is paracetamol, whether this is, I don't know, a treatment for rheumatic disease, whatever. If you abuse of that medication, if you take too many Panadols, right, then the only person who's going to suffer is you. Tough, your mistake. You sing them you dance to the music. With antibiotics, as we've seen, it's not the case. Okay, so a person's misuse of antibiotics can impact the whole community from the organism that has become resistant in that person. And this is not something new. So you may have heard about Sir Alexander Fleming, who we credit as the father of antibiotics. He was the one who discovered penicillin, and that led to all the antibiotics we have. And even as far back as the 1940s, when he was presented with the Nobel Prize, he already was mentioning the threat of resistance. And he said the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism. Maybe a bit, rather bombastic, but it's absolutely correct. So misuse of antibiotics in one person can result in another person getting a serious, potentially life-threatening infection. So what's changed? What has changed is that whereas in the 40s, 50s, and 60s, it was a very rare event that bacteria became resistant, nowadays it is widespread. So this is a map of MRSA. You may have heard about MRSA. We don't talk about it a lot nowadays, but maybe 10, 15 years ago, it was in the newspapers in the UK every day. Over here also, it's the first of what we call the superbugs. And as you can see, the darker the color, the more infections are present in the country. And there are many countries where, up to 50% of the microbial infections that are caused are actually MRSA. And it is increasing over time. So this is a map of the European region from 2001 to 2016. And the darker you get, the more resistance is present, again, in the case of MRSA. And as you can see, many countries started out green or light yellow and now have developed orange and sometimes even purple. So these are countries which are now highly prevalent with antibiotic resistance. So let's move from Europe to our small piece of rock over here. Okay, what's our local situation? So in terms of where we stand in the Eurovision contest of resistance, if I may say it so, I think we are probably on 6 points, 7 points, somewhere over there, somewhere in the middle. Okay, we're not the worst. There are many other countries, that are more resistant than us, but we're not the best either, you know. So looking at the north, Scandinavia, Central Europe, Austria, Germany, Iceland, they are nil point, you know, brilliant, no resistance whatsoever. But they are up there in the cold on their own. But compared to other Mediterranean countries, we are sort of average, if not slightly better than average. It doesn't mean, however, that it's a rosy situation. So we estimate, for example, that in Malta, this is some work from the European Centre for Disease Control, that about 600 to 650 infections every year are caused by resistant bacteria. And these result in around 30 deaths. Okay? So 30 people die from infections which we could possibly have treated better and avoided that death if it wasn't because it was a resistant infection. So, but you will tell me, listen, but we have the laboratory, we test, we have so many different antibiotics even today. True. But the problem with infections is that you take the sample, you send it to the laboratory, and it takes at least 2 or 3 days to get a result back, because you have to grow the bacterium, you then have to test it against the antibiotics, and these bacteria take their time. You're not going to rush them to grow. They will grow on their own steam. So by the time you have a result, 3 days have passed, and those 3 days are the golden window of treatment. If you don't get your treatment right in those 3 days, then that patient may very well not make it from the infection. So we're looking therefore at 30 people who has potentially died from something we could have avoided. And we mentioned costs. Okay, this is some work from the OECD. And they estimate, incredibly, of all these countries, they also included Malta, but they estimate that in Malta, this is costing the healthcare system about 3.5 million euros a year. Okay, that's not small change. You'll tell me how. Well, for example, patients who get infections will have to stay in hospital. Every bed in hospital costs around 200 euros a day. Very often, these patients stay for around 7, 10 extra days. They block beds, they stop surgery because they take up the time. We use very expensive antibiotics because very often they're resistant, so we need to use the latest. So all this, caps up. So what's driving antibiotic resistance in Malta? Well, it's basically what we said already. Let's start with the most important, and this is where we'll focus today. Antibiotics. So you may have seen this very recently in the 21st November. 21st November is Antibiotic Awareness Week. Okay, so every year, WHO, well, nowadays the whole world, initially it was the European Commission, the European Union that started this way back in 2001, but now it's taken on over these past 20 years all around the world. So in November there is a week which is dedicated specifically for antibiotic resistance and antibiotic use. And on the 21st November, we had a Eurobarometer publication. You may have heard about Eurobarometer. The EU publishes almost every month some form of survey around the European Union, with various from economics, politics, social attitudes, etc. And in this case, every 3 or 4 years, they do one on antibiotic use and how Europeans are using antibiotics. And what they found was that when they carried out this study in February or March of 2022, 42% of Maltese replied that they had been or they had taken at least one course of antibiotic over the previous 12 months. So in 2021, at least 42% of Maltese said that they had taken an antibiotic. This was the highest throughout the whole of the European Union and almost 3 times as high as places like Sweden, Poland, Germany. Now these are very cold places, Today, everyone came in with a jacket because this week has been relatively cold. It's our first cold snap. And when you have cold snaps, you tend to get infections. So these countries have cold snaps from October to March. Yet they use 1/3 of the antibiotics that we use in Malta. And it's not only how much we use. Obviously, the more we use, the more you run the risk of resistance because you're exposing the bacteria more and more. But it's what we're using it for. And when you delve deep into this deep, it's not very deep, it's very, it's standing out literally. And you see why we're using antibiotics in Malta. The 3 most common indications are flu, sore throat, and cold. And this is not something that happened recently. This was the Eurobarometer of 2016. So as I said, it's every 5 years that they do one. And this is the one that they published this year. So basically, in 2016, 51% of people said that they took antibiotics for colds, flu, and sore throat. In 2022, it's now 55%. This one. And what's the problem? The problem is that these infections are all caused by viruses. Colds are caused by viruses, flu is caused by viruses, and sore throat, with one single exception. You may have heard in the news about the strep throat that there was in the news in Europe, and we also had a case, I believe, over here. So, except for this, which is very rare and primarily in young children, sore throats are also caused only by viruses. And there is therefore, there is absolutely no indication to give antibiotics or to take antibiotics for a cold. There are no indications to take antibiotics for flu, including influenza. There is absolutely no scientific backing to this perception, unfortunately prevalent amongst many GPs, that you take the antibiotic to prevent it from going down in your lungs. Fallacy, complete fallacy. And in the case of sore throat, there are ways and means in which even you can identify whether or not this is a virus or not. Okay? So, as you hear, I had a sore throat earlier this week, and end of last week. So, it's been 10 days with this. I had no fever. I had no glands, thankfully. I had a cough, and you're hearing its remnants. And I am unfortunately more than 15 years old. Okay? So for me, it was obvious that this was a viral infection. And needless to say, no antibiotics came close to my mouth. I also mentioned the type of antibiotics. Okay, and here we have a problem. Okay, so this is again some data from ECDC looking at the countries of Europe and the antibiotics prescribed, whether they are narrow spectrum or broad spectrum. And this is again a DISPOA for us. Okay? By far, Malta uses the broadest spectrum antibiotics in the whole of Europe. I mean, compare us with, for example, Denmark. You don't even see the graph over here. And we are, which Eurovision nirpu, the broad spectrum, six Eurovisions all in one. And I mentioned animals. I won't go too much into animals, but we also have issues with animals. This is not, we are pretty convinced that this is really somewhere over here. This is the start. It's only now that they've started to report antibiotic use in animals, the vets. They didn't even get our name right over here. But probably we think it's somewhere over here. Okay, so even in animals we have an issue. So, to start to conclude, because I don't want to keep our guest speaker waiting too much. What can we do? And I'm pretty sure that he will now take this on and extrapolate further. But one thing that we need to do is we need to get better informed. Okay? And we need to pass the message. We need to be, as we say, antibiotic guardians. And why is this important? Because we still have lots of wrong perceptions amongst the population. So, for example, the Eurobarometer showed that almost half of Maltese think that antibiotics kill viruses. And I must say, okay, and I must put my hands up, both of them, okay, on behalf of my medical colleagues, because we have brought this on ourselves. Okay? Because how many times do I hear patients telling me, but I went to the doctor, he said, I have a viral infection, but you need antibiotics. So obviously, that's what people are going to think. A third of Maltese think that antibiotics are effective against colds. But thankfully, there is room for improvement. So from the Eurobarometer, about 2/3 said that they changed their views on antibiotics after hearing better information. So the more the network can spread the message, okay, the more people can hear it, both from the professionals, but also from their peers, the more we can get better. The second thing that we need to do is we cannot use antibiotics without a doctor's prescription. It's first of all illegal, okay? So no pharmacist can give you antibiotics without a prescription. It's not just that, don't leave antibiotics unnecessarily, okay? Don't use leftover antibiotics, don't give antibiotics to friends. These are not M&Ms. Thankfully, this is one area where we have made significant improvement. So I remember the first research I did back in 2002, it was at the old trade fair in Nashar. We stopped people at random over there, healthy people, and asked them whether they had taken antibiotics and whether this was with a prescription. And at that time, we found that 19% of the respondents, and we had done something like 500 people, so it was quite a nice study, they told us, no, I had taken it, I went to the pharmacy, and they gave it to me. Now we have reached somewhere around 2 to 4%. So that is very positive. But I'm sure you are saying, wait a minute, but you said that 46% of Maltese take antibiotics, but only 4% are taking them without a prescription, so where they are coming from? Well, they're coming from prescriptions, okay? But don't doctors know that antibiotics don't work on viruses? Don't doctors know that antibiotics don't work on sore throat or influenza? They do, we teach them, okay? Every year, they get through and they have to, and it's one of their questions in the exam actually, and they all answer it correctly. No, it doesn't work on virus. So why are our doctors prescribing antibiotics for colds, flu, and sore throat? And they are. Well, this is where the culture comes into it. Dr. Manello mentioned that one of my pet interests is human behavior and especially the influence of culture. And when you study culture, there is something called uncertainty avoidance. And this relates to how much societies are comfortable with uncertain situations. And this is not easy to explain, but I normally use a very simple metaphor. I say, imagine you are at the airport, and there are a bunch of Maltese and a bunch of English or Scandinavians, okay, all waiting for their flight. And all of a sudden, a sign comes up, flight has been cancelled. Okay? And do you think there will be a difference between the two groups? Normally there is. One group goes, because obviously it's a stressful situation, it's something they weren't answering. The other group will probably, say, where can we book another flight, etc. And if we look at the uncertainty avoidance amongst European countries, only 2 countries beat us for the level of uncertainty avoidance. Our friends, one Portugal, and the other one Greece. And what happens in these high uncertainty avoidance countries, and we've done research and we've published this and it's very clear, what happens is that unfortunately doctors give antibiotics in very dubious situations. It's always just in case. The 3 words which really rub me the wrong way. Just in case, It's so common in this country. And therefore, they will use wide-spectrum antibiotics, just in case, to make sure that we cover everything. And they're given also very often unnecessarily long. Or else you have someone who, like me, had a cough, they'd go to a doctor, gives antibiotics. Cough doesn't go away. Obviously, it won't because it's a viral infection. 7 days down the line, I go back, I'm still coughing, doctor. Instead of saying, yes, it's normal for a bronchitis to take 2 weeks to resolve on its own, and you're not infectious, you can go to work, take some cough syrup, and lump it until it gets better. No, we give another antibiotic because the other one didn't work. That is the reality, unfortunately. So, it's not always that doctor knows best. So, one thing that we can do is that we can talk to doctors. To our doctor to ask, Isma, is this really an antibiotic that I need? Okay. In Scandinavia, where the uncertainty avoidance is extremely low, no doctor will prescribe an antibiotic without telling the patient why they are prescribing that antibiotic. Okay. So, it's very useful for us to actually discuss with our doctors, right? Very important that we do not pressure doctors to prescribe antibiotics, because again, we know from local research, remember we have a very particular healthcare system in this country. Abroad, most GPs would form part of the NHS, and they would be paid by the NHS, and the antibiotics would be refunded from the insurance system. We don't have that system over here, so everything is from payment. So it's more of a service provider-client relationship. So when a client goes to a service provider and indicates some expectation, subconsciously the service provider is already inclined to try and assuage or fulfill that expectation. And we know that when patients indicate that they are expecting antibiotic, very often a doctor tends to prescribe it. So let's spread the message. Let's not put pressure on our doctors. They already have this cultural, millstone around our necks. That's part of being Maltese, unfortunately. And there is no harm in asking your doctor, do I really need this antibiotic? Or for example, could I maybe use a delayed prescription? A delayed prescription is one in which it doesn't start to work on the day it's prescribed, but it would be effective, say, 72 hours later. So if in those 72 hours you're getting worse, then you will use that prescription. If on the other hand, as very often happens in most colds, that they tend to get better, or not colds, because you shouldn't be prescribing for a cold, but for a cough, for example. If he is or she is uncertain, maybe it's a bacterial, maybe the patient is, towards the 50s, 60s, smoker, risk factors, fair enough, but give it a chance. If this patient is not febrile, if it's not serious, then you can use a delayed prescription. And also, if you're prescribed one of the big guns, the Augmentins, the Zinats, the Zitromaxes, the broad spectrum, the common ones, Tavanix, all of these, which are very common names, everyone knows Augmentin in this country because it's so widely prescribed. This is a broad spectrum antibiotic. Listen, do I really need a broad spectrum? Can I maybe use something which is more focused? So these are things that we can do, and I'm sure our guest speaker will also indicate what we can do more. So I will stop here. I think the network, first of all, has done a really good job on this. I think we have to work together even more with the National Antibiotic Committee to spread the message, because ultimately this is what we need to be. We need to become antibiotic guardians, because if we don't guard those antibiotics, we'll lose them, and we will suffer, and our children will suffer. Thank you very much.